the intention of today's conference is to let you know what we think you need to know about joint replacement. Now, there's going to be a lot of things that you don't know, and we'd like you to ask us, and then we can tell you. I'm ably assisted by Sister Helen Rowcliffe, who's like my right hand really, and we have a number of other people who are prepared to speak to you today as well. And I think that after we've had the formal part of this morning, you must make every use of the people that we've collected for you today. So I'd love you to go and talk to them, ask them their experiences, and ask them how they think you should use. Can you not hear them? Is that better? Sorry about that. As I was trying to say, we've collected a number of people for your benefit today, and the idea is that we tell you what we think you need to know, and having done so, you ask us lots of questions. And then at the end of this, there's plenty of opportunity for interaction, both with myself, with Sister Rowcliffe, with some physiotherapists, Ed Hollis and Julian Russell-Jones, who very kindly turned up, and as well as that Sister Porritt, who's actually the manager of National Capital Private Hospital. And I've also, and this is a bit scary, I've brought along 2 previous patients, and so you can ask them what really happened. And so there's no glossing over what we might have done and said. So, I'm sure you're all here for a reason. And this is the agenda. Sister Rowcliffe and I are going to have a chat for a bit. And then Mr. Hollis is going to tell you what he thinks you should do. Ms. Porritt will let you know what happens at an administrative level and at a nursing level. And then we'll have the patients that you can interact with. And then we'll have a discussion. We'll deal with the hecklers if we can, because there are usually a couple. And we'll also encourage you to consider looking at the exhibits that we have for you. And you may or may not be aware that there are lots of things in the community that can help you with your disability, whether that be by home help, whether that be by simple things like toilet seat risers, which sounds terribly prosaic, but is amazingly helpful. Simple things like putting handrails next to your toilet and so on. We'll get onto that later. Then we'll have tea. And we have decided to go straight through with this and not break, just to continue with the continuity. I was talking to Craig Dean, who's one of my patients here, just before the conference started. And the thing that he said was most important for him was making the decision to actually go and do the operation. And whilst people know a good deal about this process, or they think they do anyway, actually committing yourself to this is not something that's necessarily easy. And I think you'll find that, in global terms, this is going to be your hardest decision. I want to start with a couple of quotes. I got this out of a book that my wife's reading. Donald Rumsfeld said, "As we know, there are no known knowns. There are things that we know, we also know there are known unknowns. That is to say, there are some things we do not know, but there are also unknown unknowns. The ones we don't know, we don't know." Now, if you can make sense of that, you're doing better than I am. But George Bush said it even better. The trouble with the French is that they have no word for entrepreneur. Which is, of course, a French word. And at the second annual National Conference on Government Portals, now I don't know what government portals are, someone said that the whole objective was to enhance availability and accessibility of services for the end user. What does that mean? I don't know. We're here really to give you plain speak. And if you don't understand what I'm talking about, like George Bush, then you need to put your hand up and ask me. Right? Well, why are you here? I presume you're here to get information from us. You are probably here to settle some fears that you may have, or even confirm them. You may be having difficulties deciding where you need to go with your problem. And you may have a relative or a friend who's here. There are many misconceptions, and I think that this is an important thing to deal with. A lot of people think that the process will be very painful. A lot of people say, "I will take a long time to recover from this procedure." It is very risky, isn't it, doctor? Is a common thing that people will say to me. It won't last very long, people say. I'm too young. I'm too old. And there are probably other things which I'm grateful to hear about, but these are probably the main things that I've experienced in my practice. That's my dog. Well, why am I here? I'm here to help you with your doubts and fears, and to also refer you to people who are less scary than me, and who are just lovely to talk to, like Helen, and also to give you the opportunity to understand that there are many, many facilities available to you, to dispel the myths that may be associated with this whole process, to tell you about where we are with trends in joint replacement, and to talk about the future and whether it's relevant, and to talk about the team approach. Well, let's talk about the team first of all, and I've already made a substantial play about this. At the bottom level, there's often your general practitioner. Now, your general practitioner may not know anything about this, but the general practitioner may be your best source of information, and it's sometimes very difficult to know whether they're on your side or whether they don't actually know much about it. But in general terms, most general practitioners are very well versed with the management of osteoarthritis or rheumatoid arthritis. They're very well versed as to when to tell you to go on, and they're your best friend, really. They're fantastic. But some of them don't know much, and some of them are forced to practice 6-minute medicine, and they're not really interested in you because they can't be. If that's the case, you must move on to somebody else, not necessarily a doctor. There are administrative staff in my practice and in everyone's practice. My girls, Karen and Robin, are simply fantastic, and you must feel that if you needed to discuss things with them, just pick the phone up. We send them an email. We have nurses both within our practice and also at the hospital level, and there are nurses then beyond that in the rehabilitation facilities, and even beyond that in the community. So there are lots of supports. The nurses will assess you before the surgery is done. They will look after you on the way to the operating theatres, in the ward, and things will go on from there. This is Helen and I just doing a little knee replacement. There's not too much blood here, which is quite good. In addition to that, the team is extended by physiotherapists that we involve before and after your surgery, and occupational therapists to a limited extent. Occupational therapists are very useful people because they help identify the problems that might exist in your house. And these are probably issues that you don't even understand, like having too many mats on the floor, which represent a risk to falling, not having sort of adequate facilities to know when you get on and off the toilet. Boring things like this, which are really important. I'm the surgeon, I do things that are very important. Physicians. We sometimes involve physicians who are basically specialists in internal medicine. Their job is to look after people who might be a bit sicker than the general population. People, for instance, who might have diabetes, unstable heart disease, respiratory problems. And I involve these people usually before the surgery, and they'll look after you in the hospital as well. The surgical representatives, they're people who come along to the operation and who give us and provide us the prostheses that we use for the surgery. These people are actually very valuable. They make sure that the equipment's there for me. They make sure that if I need special equipment, it's available. And if things are special and we require difficult things inside the surgery, they get them for us. And my computer, which I think is very important. So I'm clearly not on my own in all of this, but in fact I choreograph the deal. And the buck stops with me. So if there are problems, it ends up in my hands, and we're very good at managing whatever issues arise. So my job is to be competent and experienced, and I am, and I've done lots of this. We have to offer you what we think is the right thing for you. And I think that's a very pivotal part of this whole process. Assessing you on an individual basis, working out what's the best treatment for you, and timing that treatment.